Welcome to another explainer, where today we're basically becoming medical detectives. We've got a patient, we've got a mysterious swelling, and we've got a trail of clues. Let's see if we can solve this thing together.
So here's the deal. We're going to walk through a clinical case, step by step. I want you to pay close attention to every clue we uncover on each slide and see if you can figure it out before the big reveal at the end. You ready? Let's jump in.
All right, first things first. Every good investigation starts with a person and their problem. So let's meet our patient.
And here it is, our central mystery. A 45-year-old woman comes in, and this is her one main complaint, a swelling right in the front of her neck. This is our first and most obvious clue.
Now, along with that swelling, she's feeling these specific things. She's having some trouble swallowing and feels this tightness in her throat. That tells us this isn't just something you can see, it's physically impacting her. These details are absolutely crucial for our investigation. So, we've heard the patient's story. Now it's time for us to gather some hard, objective evidence. We're shifting from what she's feeling to what we can actually measure and see with exams and lab tests.
And here we go. This is a huge clue from the physical exam. The mass feels firm, we know it's about 3 centimeters, but the really interesting word here is non-tender. The fact that it doesn't hurt when the doctor presses on it, that's a big deal, and it's going to help us rule some things out later.
Next up, her vitals. We're looking at her blood pressure, her heart rate, her temperature, and everything looks stable, right in the normal range. Now, this is an important clue in itself. It tells us she's not in some kind of major distress. There's no sign of a big infection or anything a body-wide crisis going on.
Okay, and now for the lab results. This is a game changer. We've tested her thyroid hormones, and look at that. Both her TSH and free T4 levels are perfectly normal. This is such a critical piece of the puzzle. It means that even though there's a physical swelling, the function of her thyroid gland is totally fine. It's not working overtime, and it's not slacking off, which really helps us narrow down the list of possibilities.
And finally, the imaging gives us a crystal clear picture. The ultrasound confirms what the physical exam hinted at. There's a solid mass, and its location is pinpointed. It's right inside the thyroid gland. Not next to it, not near it, but in it.
All right, we have gathered our evidence. We have a single, non-tender mass. It's inside the thyroid, and her hormone levels are normal. So let's line up the usual suspects for a case like this.
So, what's your call? You've seen all the evidence we have so far. What do you think is the most likely diagnosis?
Here's our lineup. Is it A, thyroid cancer, B, a goiter, C, a thyroid nodule, maybe D, an inflammation called thyroiditis, or could it even be E, swollen lymph nodes, something called lymphadenopathy? Each one is a possibility, but only one is the most likely based on the very specific clues we found.
The moment of truth. It is time to put all the evidence together, draw our final conclusion, and officially crack this case.
Before I give you the answer, let's just make sure we're on the same page with this definition. A thyroid nodule is just a distinct, separate growth inside the thyroid. The keywords there are discrete lesion. It's one specific lump, not a general swelling of the whole area.
And there it is. Based on all that initial evidence, the diagnosis that fits best is a thyroid nodule. So if you guessed C, congratulations, you've cracked the case.
So, why is this the right answer? Well, it really boils down to these 2 key facts. We found a single distinct mass, which perfectly fits the definition of a nodule. And, just as importantly, those normal thyroid tests tell us this is a structural issue, not a hormonal one, which is super common for thyroid nodules.
But, a good detective doesn't just point to the right suspect. They also have to prove why everybody else is innocent. We call this the process of elimination, and it's what makes us confident in our diagnosis.
So let's just quickly run through that lineup one more time and see why the other possibilities don't really fit the evidence we have.
First off, why isn't it a goiter? Well, a goiter is when the entire thyroid gland swells up all over. Our patient has one specific 3-centimeter lump, so it's the difference between a diffuse enlargement and one single focused mass.
And what about thyroiditis? The itis part of a word means inflammation. And what does inflammation usually cause? Pain or tenderness. Our patient's mass was non-tender, and her hormone levels were normal. Both of those facts make thyroiditis very, very unlikely.
Could it be lymphadenopathy, which is just a fancy term for swollen lymph nodes? Nope, and we know this for sure
because the ultrasound confirmed that the mass was inside the thyroid gland itself. Lymph nodes are separate things that are near the thyroid, not part of it.
Now for the big one, cancer. It is incredibly important to understand that while thyroid nodule is the correct initial diagnosis, we can't rule out cancer from this information alone. To know for sure, you need a biopsy, which is pending for this patient. But based purely on this first look, nodule is the most accurate description of what's going on.
So, if you remember one thing from this whole case, make it this. When you see a single, distinct mass in the thyroid and the hormone tests come back totally normal, your #1 suspect should always be a thyroid nodule.
You know, we had a pretty straightforward case today. All the clues pointed neatly to one conclusion. But that leaves us with one last, lingering question to think about. How do doctors figure things out when the evidence is messy, when the clues contradict each other, and the symptoms don't fit any textbook? Well, that's a puzzle for another time.